Dr. Kumar. Dr. Kumar, can you hear us?
I am okay. If you are getting connected, I am okay.
Yeah, fine. So please present your case.
Yeah. Just thank you for everybody. Can you see us and can you?
We can see you, Dr. Pratap.
Very good, very good. Thank you very much. So along with me, Dr. Blesswin, our senior cardiologist will present the case and then we will go back to the case. Can you just present the case?
Yes, sir. Good afternoon, and all. Our case is a 76 years old gentleman. He was a known case of diabetes, hypertension, dyslipidemia, and hypothyroid. He had an antivolamide on 2014, for which primary PCA to LED was done with 2 stents. And now he presented with NSTEMI, and echo showed antival hypokinesia with the EF of around 50 to 60, and his serum creatinine was 1.29 with the eGFR of 57. So the angiogram showed there is a significant LMCA, distal LMCA disease along with ostial LCX tight disease. Ostial LCX was having acute angulation, and there is a significant disease of the LAD stent also. Next, you can see the acute angulation of the LCX, and there was a calcium also in the LCX ostium. Next, RC was non-dominant, it was diffusely diseased, and we are proceeding for LMCA bifurcation PCA.
Thank you. So I can't see the LED stent. Does it come all the way back or?
Yes, sir. LED stent is in the proximal to mid segment, and also there is a distal LED stent.
Okay.
2 separate stent, and there is area in between.
No, not post catheter.
Can you just, now you have seen the case?
So what I understood from this presentation, this is a distal left main situation, and you have to approach now practically this distal left main case. So your plan will be to wire both to make some plug.
Yeah, basically we have to wire both the vessels, but the angulation of the circumflex. But this angle, you can see that an angulation is very it's a very bad angle. Whether it's actually look like you have to make 2 curves. I actually did not start the case, and they just took 1 wire, filter FC. I tried to pass the wire. The wire was difficult to go. I made secondary curve, and the wire went inside, and now I have to take. That was the first shot because I was thinking I'll be coming late. So I'll be showing next, Anju. Next
Pratap, it's Dr. Radash here.
Yeah, please.
It's a trifurcation. There's a significant ramus also coming in. So do you give some importance to that vessel also?
We can give importance, but I was thinking that I'll just put a wire. See, this is the wiring part. Just I'll be telling you, this is the wire part of the, it went into the small branch, but I took the wire. Next. The wire actually taken back, and then you can see that the wire is actually taking a bend. It's actually the secondary curve is made. Now I'm actually making the wire gone distally. Then next. Now I took the wire into the LED. After that, this is actually this much only done. So now the wire is going into the proximal part of the LED. It is crossed. This is the area where I just reached. Can you just give a check?
Yeah, for younger doctors, if you have problems to cross ostial circ because of such difficult angulation, you should have in your cath lab supercross microcatheter.
Yeah, that is one way.
Or angulated tip, and this is where then usually using polymer wire, soft polymer wire will cross.
There are 3 ways to do that. One is actually you can take a polymer jacketed wire. Number 1, making a secondary curve. Second is actually, as you told, you can take a supercross and cross it. Number 3 is actually you can take double lumen catheter and keep the wire into the LED and take the next wire, right? This is actually the third one. Or sometimes, even if you are not able to do it, you may dilate the LED ostium and then create a path for you to take in. That will be the last resort when you wanted to do that.
Yeah,
that's a good tip, Dr. Pratap. So what are you thinking? What's your strategy going
now
forward?
My strategy is to actually pre-dilate the lesion and then an imaging and then go ahead. First of all, I just wanted to pre-dilate because I don't think the wire will go inside before doing anything. So my plan is to do pre-dilate with a You can actually take any balloon, but I just decided to take a 2 millimeter balloon and then see the circumflex. And then I will decide the real pre-dilatation by cutting balloon or a normal balloon. I'll take a 2 millimeter balloon immediately going to the circumflex, and that is the tightest part. The other thing I can actually manage easily. So I'll take a 2 millimeter balloon, 2 into 12 millimeter Maverick balloon. I'm going to take it. Any
Okay.
comments?
So, no, I think that seems like a great strategy, Dr. Pratap. As we were discussing yesterday, I told you that on the panel, I'm going to oppose everything that you say.
Yeah.
So we will hold you to it.
But do you think that this RAM is actually, Dr. Radhakrishnan told whether we will take it as a trifurcation? I can put a wire there. I was thinking that after balloon dilatation, I can take this ramus is actually originating from little away from the either it is an OM1, early OM1 or a ramus, you can define. So this is actually the point. So now I'm actually going to dilate this part. The balloon easily gone inside. It's a 2 millimeter balloon, not a very tough balloon. 10, 11, 12, 13, 14, 15. I just wanted to do the imaging. Only for the imaging catheter to go, I decided to take this balloon, because if I decided to take an OCT, because everybody is doing OCT, I also wanted to do an OCT today.
Okay.
Yeah, I could imagine this if you see in imaging a lot of calciums,
Deflate.
a lot of calcific.
No,
lesions.
moreover, actually, the patient had a stent inside the LED. So this LED stent, whether LED stent, calcium is inside the stent or calcium is outside the stent, which I don't know. So probably there is a stent inside the calcium inside the stent is also there. So
Yeah.
we have to do something in really there. But I was thinking that the stent is probably protruding into the circumflex.
Yeah,
but it is not.
Dr. Kumar, this is a really nice introduction. So probably you will go ahead with IVL balloon, shockwave balloon. We switch now to Medanta, to Dr.
And then come back to me. No problem.
And we will come back later to you.
No problem. No problem.
Dr. Pratap, we're back.
I am also ready.
How do you
we-
approach?
We
Show
just
us.
did a balloon dilatation here. Next. We did an OCT on the circumflex first. Can you show the OCT? OCT. OCT. Can you just show the OCT image big? Okay. Blesswin, can you explain?
Yes, sir. You can see the circumflex. There is a lipid flock distally, and followed by this is a ectatic segment, and proximally there is a calcium. You can see this is a lipid area, and proximally this area has a calcium. It's around from 11 o'clock to 7 o'clock.
Less than 90-degree arc.
Then proximally there is a fibrocalcific lesion and some thrombus you can see. So
Very tight. This is a nostril part of the LED circumflex, but which is actually less than 7 millimeters. You can actually provisional stenting or not. This is a discussion here. But the point is actually the patient came back with a reblockage in the LED stent. So we have to put a stent from the LMCA to LED. So I decided to do a stent from the circ ostium mid part of the circ, which is actually the normal segment, which is looking like a 3 millimeter vessel. Can you just show the distal beyond the ectasia? What is the size of the vessel?
Yes.
That will be look like what is the size? 3.15. So we will be just taking a 3 millimeter long stent. What is the area length? 28 millimeter circumflex. And now you just go to the next shot, angiogram. Angio shot. We will just discuss this part. We actually, Dr. Radhakrishnan told I have to take care of the ramus also. So I took a wire. I made a small bend, and the wire is taken back to the LED directly because the wire was sitting in the diagonal. So my wire easily went into the LED now. So I taken the LED wire. LED wire is taken back and then put into the ramus. So this is the situation. Can you see that this wire is taken back? And I pushed the wire into the ramus. He was very much worried about the ramus, so I just decided to put the wire into the ramus. Next, I decided to do an OCT run. 2 runs I have taken because there was a stent in the distal part. Can you show the first run of LED? Blesswin, can you explain? This is the first run of LED.
Stent. There is a diffuse neointimal hyperplasia, and proximally, you can see the area is only around 2.3 and the tightest part was 1.99. There is a, these areas are having some calcium and fibrocalcific lesions.
Now we will come back to the next shot, which is actually covering next OCT run,
Yeah.
which is actually taken up to the LMCA because we decided to take one more run. This run, this is actually covering up to the LMCA. Can you just see that? From the distal part where we were feeling is the disease, little more distal, little more distal, little more. This is actually an area where we can land the stent, which is actually like a 3 millimeter, 3.03 is the length. So we just come back to the LMCA part. Tight disease, tight. These are areas are 2.37 in the proximal LAD. Just come. There is all stent strut there. Come back. Come back. Come back. And this part is a very, very tight disease, nearly 0.94. That is the osteoproximal part of the LAD, which is actually, you can see the branch coming up. If you go up to the LMCA look like, can you just show the LMCA? LMCA, this area is looking very good. Can you show the length, diameter? Vessel diameter is nearly 4.15. So yesterday I discussed, Saurabh, I was discussing that when I have a 3 millimeter distally and a 3.4 millimeter proximally, there is a 1 millimeter difference. So my strategy here will be a 3.5 millimeter stent, 48 single stent, and a 3 into 28 into the circumflex, and keeping the ramus balloon dilatation. And before that, I prepare the lesion, both sarcoma and LAD ostium, with a cutting balloon. I'll take the cutting balloon directly with a 3 millimeter cutting balloon minimum, because I just wanted to take care of the circ as well as the LAD. So I don't want to take a 3.5 and take 2 cutting balloon. I'll take 1 cutting balloon, dilate the circ ostium. Then I take the same cutting balloon, I dilate with the LAD ostium, and then I do a pre-dilatation of the LAD part, again with the 3.5 millimeter balloon in the proximal LAD, osteoproximal LAD, and then I will do a decay crush. What is your suggestion?
I think that looks to me, I'll ask the other members of the panel. I mean, I think that's, at least based on my experience and the data, that seems to be the best strategy here. What do other people think? So everybody seems to be in agreement. There are lots of head nods.
So
Actually,
please,
Saurabh, you understood. People are agreeing with me. Thank you.
Dr. Kumar, please go
Yeah.
ahead with your decay crash approach, and we go back now to Dr. Chandra.
Okay. I
Prathap,
can actually.
so many people used to do them in USA. So in Sorma, they are 90%, more than 90% cases, they mini cross, even that type of lesions.
No,
And
we
their
will,
result is
we
very
will-
acceptable.
Sir, we can try with DK Crush, because DK Crush has multiple steps here, but I think there is a time up to 4 o'clock. I personally feel that Dr. Chandra and Dr. Rath will allow me to show the steps properly.
Yes, and we would like to go back to Dr. Kumar,
Mike, you got it.
to Kollam.
Oh, Mike, you got
Dr. Kumar,
So
you are
now we
back.
are actually, okay. I decided to take a cutting balloon now. This is a cutting balloon I'm going to take into the, no, cutting balloon was actually not going down to the circumflex ostium.
Not
But then-
crossing.
No, it is not crossing. So cutting balloon 10 I have taken, not 6, I'm just telling you. It is a 3 cutting balloon.
No,
So
sir.
next, I decided to take a small balloon dilatation in the ramus. That is a 2 millimeter balloon. Next, I removed that wire. I was thinking the wire is wrapping around and creating confusion for me. Next. So I was actually taking everything. Now again, I've taken the cutting balloon. The cutting balloon is again not crossing. Then I understood the lesion is the problem, not the wire wrapping. Next, I took a balloon dilatation with a 2.512 balloon. Just can you show the balloon is coming and balloon dilated. It was really difficult to enter inside, but I just dilated the osteoproximal part. Next. After that, I took the cutting balloon. This is the cutting balloon again. See, this it has easily gone down. No, this is the cutting balloon. I dilated. I think that is the same balloon. I think the normal balloon. Next.
What you could use is guiding extension, maybe.
I could have taken that, but I just decided to take a next, it is coming. This is actually the cutting balloon I was trying to take into the LAD. Again, it was difficult. So what I decided is again a balloon dilatation, the LAD osteoproximal, which was very tight, only 0.94, you remember OCT. This is actually a cutting balloon, inch by inch. I just pushed the cutting balloon. Next. Now, this is actually the situation I am standing. So now I'll take an injection to understand what the balloon dilatation, or now I'll just go for the stent before doing. This is the preparation I have done so far.
So, but your suggestion was to stand now first from left main to circ or
No,
to LAD?
circ.
To circ,
Only we
right.
can do a DK crush.
I think
then-
I'm not sure, probably if you stand from left main to circ, perform POT, and then perform final kissing for LAD and treat this proximal LAD segment with drug-coated, because it's in stent restenosis, you could also go with drug-coated balloon approach.
That's actually a very good suggestion, but I just wanted to put a stent from LMCA to LAD, where the drug coating balloon cannot do anything on that. So when you do a circ stenting, the stent strut will definitely protrude into the LMCA. So the two stent struts, this present stent strut and the previous stent strut protruding into the LAD, I think it LMCA, I don't think it is a good suggestion at all.
I'm not
What do you-
sure, but you have to perform final kissing with NC balloons. And
No doubt about
size.
that. What do you think? Now I'll go with a stent into the circumflex and then balloon dilate and crush, then followed by a recross and then DK. Then I just go with a stent from
No, you
LMC
have
to
still
LAD.
an excellent option to you to go here with a culotte approach, Dickey culotte. I don't know, why do you want to make Dickey culotte?
We like DK crush, you know, the principle is actually DK crush, DK crush, DK crush. That is,
Prathap,
yeah.
there is a great diameters improvement of the ostium diameter is. So why not using the DCB? So that case is very beneficial. in
The
this-
DCB actually, when you have an osteal circ has a tight disease, when you actually almost dilated the vessel with a 2.5 and a 3 millimeter balloon, definitely it creates a lot of dissection there. I'm not going multiple injections now. I just wanted to do an OCT later. But if you do that, I personally feel that with an osteal tight circumflex and osteal LAD disease, I'm actually very much worried that the patient will have, the benefit will go away. And moreover, anything happens to the patient, this is actually, I'm taking a 3x28 stent. I just stent is gone down. You can see that stent is actually taken down. Now I will take a 3.5 millimeter balloon minimum. I'll just take for a crush. 3.5 millimeter, 3.5 into 12 millimeter balloon. And after that, I'll recross into the circumflex and create a first kiss.
Dr. Pratap, I agree with that strategy. You know, I'd myself be reluctant to use just a balloon in the ostium of that circ. I think the downside is a bit scary.
Moreover, yesterday, Saurav, we have seen two cases where we have seen strut going, and we cannot be as ostial as possible. And I don't want to dilate both the places and keep something there and the patient. I don't know. I'm actually a little worried about that.
Do you think that now that you've modified the bifurcation so much that it'd be relatively easy to wire this?
I think it is actually, let me see, the wiring is actually the thing I wanted to show people, not the anything, because this I'm keeping this because it's a science stent. You can see that the advantage of science stent, actually the ostium is actually, you can see that the marker, not at the stent away. So when this is actually looking like a perfect ostial positioning because the strut is extending up to the marker. So I think I can go ahead with a balloon, stent go. Go.
You plan now mini crush, correct?
No. After balloon dilatation,
DK crush.
then DK crush. That is my plan. Not mini crush. Mini crush I do routinely, but here this is in a teaching program, so I just wanted to show a DK crush. I will have some difficulty in recrossing. Definitely, I know that. If the difficulty is there, that I wanted to show people that I have difficulty.
To be honest, for me, you should have a bit more protrusion from the
I
stent.
think we will see, definitely we will show this one by an OCT and tell that my ostium is covered. That is more important. We do
Yes,
actually
but
a
your
modi-
ostium should covered by
no, no,
minimum
modification of the
3
modification of the
millimeters.
modification of the ostial decay crush now is taking the same balloon back, go at a high pressure and dilate. That is what actually the side branch optimization. Can you go with the 15 atmosphere now? No, same stent balloon.
That's a bit different approach to Chinese guys.
The
because
Chinese
they
guy only told,
recommend-
Chinese guy only told this. Actually, the Chinese guy only doing that. Now he is doing a modified decay crush actually like this. He just do a balloon dilatation so that the ostium of the circ will get well opened up with a high pressure and with the same stent balloon and then take the balloon out. This is actually the Chinese guy does. So the Chinese guy, the Shen, he is also our close friend. Actually, Chen is telling that now he modified the decay crush by this technique. So he is telling that produces easy coverage of the ostium. So you told that ostium may not be covered. I don't know, but let me see that. And you can take the wire out or not to take the wire out, but I'm taking the wire out. And then I'm going to do the first crush.
To be honest,
go.
you didn't check this by angio. Now you removed the wire. Maybe you have a distally huge problem, and I'm not.
That is actually correct. Actually, I did a mistake there. Actually, I should admit that was a mistake. I usually check, and if there is a problem,
Yes,
I usually go with a balloon. Again, go with another stent distally if there is a dissection I created. I usually do that. In the rush, I forgot or I actually missed to do that.
Yeah, no problem. But at the moment,
I admit.
At the moment,
you immediately found out that. That is very good.
So at the moment, your stand in circ looks nice.
No, but now I will recross.
You have to go now with the pot.
Can you just give me
and
the
then recrossing.
People recross after a pot. I can actually recross. Even you can try without a pot.
No,
Ideally, you have to do
listen. Do you like to go by step, like recommended approach, or it is your modified personal?
Then you can do a 4 millimeter balloon and then give a 4 millimeter
because
balloon.
young doctors will be confused.
You can give a 412. We will actually do a pot and then
please
recross
go
fast.
step by step, like recommended. Because if you do your own way, so nobody knows what is really classic approach. Standard.
Correct. I will do that. I will actually do a 4 millimeter balloon. Now actually crushed with a 3.512. Again, you could have taken a 4 millimeter balloon and the crushed there. But the ideal way is actually the proximal part of the stent on the other vessel is only a 3.5 proximally. So I don't want to take a 4 millimeter and dilate more. That is why I decided. Now I just do a crush with the first pot. This is actually the pot I'm just trying to do.
This pot is very essential to recrossing the side branch.
So actually you may be able to recross as you told. Ideally the step should be like this. Go. 15. No, it came down.
I think just go with the pot and then
Small check.
with recrossing, and we would like to see this recrossing. But
I will just show.
Between, we go back to Dr. Chandra.
And I'll try to show the recrossing, deflate.
Yes.
See, this, just one shot back.
Okay, there we go.
So,
We're back, Dr. Prathap.
Yeah. Can you see the wire crossing? Next. Balloon dilated.
Yeah.
Wire is crossed like this.
Okay.
Next. We took a balloon, the same balloon I used for the pre-dilatation. That is a 3.5 millimeter balloon, not even 2.5. I took a 3.5. I just kept the balloon there. I took the ostium and dilated. I pushed the balloon a little more. I just kept the balloon and pushed some more. I just went into the ostium. Then I pushed again. Now the balloon is actually dilated in the proximal part. It's a 3.5 millimeter balloon, which is already used for the pre-dilatation.
So the proximal strut is used.
Proximal strut. And both actually, now there is a 4 millimeter balloon in the LOD and a 3.5 in the circumflex. And with the kiss balloon, deflate, deflate. Next. After that, we have taken a 3.5 into 48 stent. The stent is going inside. Now the stent, there is little difficulty, but I could take the stent down. This is actually the situation now. Now I am actually checking the shallow cranial to understand that my stent is up to the ostium or not. I just wanted to take a 3.5. Yesterday there was a long discussion. It's a 3.5. The distal is looking like a 3 millimeter vessel, but I took a 3.5. The normal atmosphere pressure is actually 10. So we will go only with the 8 now. Can you see the what is 11? What is the 8? What will be the 8 atmosphere?
And we can see it, but what I can't make out for sure is the distal part of that stent inside the older stent.
Older stent, correct.
So it makes it even safer.
3.31 will be the size when I dilate in the 8 atmosphere. So I will go only 8 atmosphere now. Go 8.
And we had a long discussion yesterday for those who care on what is the optimal strategy when you have a size mismatch. And we discussed the pros and cons of a lot of different strategies on whether to undersize and then aggressively post dilate.
You can see that actually the distally the side of the balloon is opened up. Now I stop here. I will withdraw the balloon, the same balloon. We can see an ST elevation now when I dilate this part. So patient is getting severe pain. So I'm just going to take this balloon out and I'll take a normal 3.5 millimeter balloon.
We see some ECG changes, but ECG normalized.
Coming back, it's normalized.
No, basically because that is the 3.548 covering up to the LMCA, then naturally I was expecting. So we should not keep the balloon inflated for a long time. I was actually just for the discussion part, it was little there. So I wanted to take a 3.5 balloon in the middle part. I have to dilate very well. And
I think it's very useful what you just recommend to go distally to make post-dilatation, then to take larger balloon for pod, then recross distally, final kissing, final pod, and then final imaging. Great approach, Dr. Kumar. We just go for short time back to Medanta because. Okay, so we go back now to Dr. Kumar.
Okay, can you just show the last 2 shots? Go back. So this was the stent I placed. Can you see? Next.
Yes.
Okay. Stent inflow. Actually, there was next. I took a balloon 3.5. I'm actually dilating that part, which I went up to 18 atmosphere. The same balloon 3.5 taken for the initial pre-dilatation, which I went up to 18. Now it is 20 in the proximal part. I dilated. I did not go to the distal most part. And then now I reasonably produced. And next I took a 4 millimeter balloon and 4 millimeter balloon and dilated that proximal part again. Now I just go and recross the circ. That is what is my challenge. After that, I have to show the final OCT. I think I have 7 minutes. I may be able to do that.
You're going to make it look easy again, Dr. Prathap.
We believe you.
The wire gone.
There you go. So what I want to know is
this was 1 second crossing. Congratulations.
Thank you.
Thank you. Excellent.
Now we will go with the OCT first. To see the OCT run, then kiss and then come out. Because if there is no time, I will not be able to show the OCT.
Yeah, we want to see the OCT, but we don't want
to. Because especially he told that probably I don't know whether I would have definitely covered. I did not do one thing which we do usually. We do a fluoro clear stent and understand that balloon is the stent is actually had ostial covering is there with the 2 layers. You can see it once part. Can you just come to the epicranial?
Prathap, I'm Dr. Srinivas Kumar here. No problem for time for you. You can do whatever you want coolly. We finished any other 2 cases. We'll close whenever we want. Okay. Thank you.
No, it is not like that.
Although looking at the speed you're proceeding, Dr. Prathap, it doesn't look like it'll be that long.
Yeah.
No, it is actually the OCT catheter gone inside.
Take your time, guy, because the world needs you.
Now, ready? I take a 10 ml syringe, 10 cc syringe only, not 20 cc syringe, which actually many people still reluctant. It is a 10 cc syringe. Okay, ready? We got with a 10 cc syringe. Let us see what is the result.
Very nice. Yeah.
Yeah.
Quality is excellent.
People are reluctant to use a 10 cc. They take a 15 cc syringe, and in saline also we take a 15 cc. In normal OCT we take only 10 cc. Can you see the OCT distal part, the most important part? We took a 3.5 millimeter balloon. Can you just show that properly? There is no edge dissection. Saurabh, this is the point I was telling yesterday. There is no edge dissection is created by that, and there is some more dilatation required in the distal part, which actually I was reluctant to do because the measurement was only 3 millimeters. So I just went with 8 atmosphere, which created 3.31 by definition of 8 atmosphere by post dilatation.
No, you and I were exactly on the same page. That's exactly what I like to do when there's vessel mismatch. I mean, we were talking yesterday that in the US, at least, we also have access to a Megatron stent. But this is such a great strategy.
And can you show the bifurcation now? Bifurcation. No, we did not do a bifurcation balloon inflation. Can you take the balloon? We did not do the balloon inflation. We did not do a creasing now. We wanted to know how many struts are there. Lot of struts. Well, not clear.
Yeah, maybe it's possible to do this
Excuse me, sir.
under OCT view.
Excuse me.
Yeah.
Sir, may I have a question, please?
Yeah, please ask the question to 2 people are there sitting there. They will give you answer.
Just I wanted to know the previous LED stand which was placed during the previous
balloon
coronary event. It was up to the ostium or beyond the ostium?
Up to the ostium.
Up to the ostium.
Ah.
So in this case, one option can be we place the stent, single stent from left main to LCF, and we prepare the LED ISR lesion very well with the cutting balloon and other methods. And
No. Then the strategy should be from LMCA to circumflex one stent, and you do a power bar to the LED ostium. But LED ostium not fully covered by the. We have seen the OCT. The OCT was showing 2 millimeters, 1 or 2 struts actually away, 1 millimeter away from the ostium. So whatever you do, you may not be able to get the same result. Now I have a struggle to take the balloon.
Okay, LED ostium was not fully covered.
Not fully
With the
covered.
previous stent.
Yeah.
Okay.
Pratap, this patient, the distal LMC disease less than 3 millimeters, so near the ostium. So therefore, this case alternative V stent can be used also. Of course,
V stent and SKS are not the 2 techniques, but it is proven to be not the good techniques. These are all if there is no chance you can use, not the routine chance, not the routine. Can you just come back to the see that mother, my wire is underneath the stent or not? Wire is underneath the stent or not? Not very clear. Okay, because actually, can you just come to RIO caudal? My balloon is not going, but the same balloon I have taken, same balloon means the 3.5 balloon. Now it is gone. Now we will actually, can you just see a clear stent and see the balloon again, the 3.5, which is actually used for the 2-3 purposes, and the same balloon gone without any problem. I will do a clear stent and understand where it's circular.
But today you are extremely lucky to cross between struts with already used balloons.
See, actually, my balloon is sitting inside exactly in the middle part.
Yeah.
So mid cross, almost like definitely non-distal cross is actually what he's telling. Can you just make a balloon dilatation? Inflate.
Mid cross also acceptable.
Mid cross, no, it is actually non-distal, sir. There is nothing called proximal cross. Actually, the best one is to have a non-distal cross. The DK Crush Chen is also not telling that you should do a distal cross. Non-distal, that is what.
Chen already compared both proximal and middle is accepted. The equal result.
Deflate. Can you just take a 4 millimeter balloon?
Well, one thing, before each pressing, there is side branch dilatation, but NC balloon in high pressure is a mandatory.
No, actually, we went up to 15, sir. 15. That is actually the point. 2 balloons go with 15 separately, then both the balloons should go 8 or 10 or 12 according to your choice. But the people actually, I personally feel that you should not go beyond 12. So because it is not good, the carinal shift will happen. So
Correct.
now I am taking a 4 millimeter balloon into the LAD, which if the balloon is going easily, then I should understand that things are okay. The same balloon I have taken, again the balloon is gone. So as he told, I am lucky today. So balloon inflation 234, 234. Actually, when the balloon is not going, what I do is actually a small balloon inflation and then go deflate. Now I push the balloon. Now the balloon is gone inside. So I do like that because these are all, we are not in a rich country. So we have to learn all these small techniques to save the cost for the patient.
That's a very good trick.
No, now you can go
Do you
LED
go
LED
sequentially or do you go simultaneously?
No, initially we go sequentially, now deflate. I will go circumflex 15. Deflate.
Yeah.
Now I will go both together at 10 and no, they are very aggressive people, my people.
You have to go
So-
back with a circ balloon, I think.
Yeah, now it is okay. So now we will go together at 10. The most important part is the deflation should be equal, not the inflation.
Yeah.
So this is actually the inflation is okay. Now I will go with the deflation with the cine. Deflate fast. So the girl is very good and the boy is not good. So
So this is your final case.
no, actually the final kiss actually done. Now I can take the balloon back into the
Okay.
same 4 millimeter balloon can be taken into the LMCA. If you want, you can do a pot. Yesterday we were discussing 4 plus 3.5 will be 7.5. So ideally you should have a 4.5 balloon as the LMCA part, as the pot, final pot. So that is what is actually, but initial measurement showing it is only 4 millimeter vessel. What do you think? I have to take
Yeah,
a
correct.
4.5.
You know, based on the OCT images, it seemed very reasonable.
20.
Yeah.
I kept the balloon exactly. You can see the marker. I'm just
Correct.
away from that part. And then now deflate. Deflate.
Yeah.
Stent placement, you can see the stent. Can you just look at the, this is a clear stent. Can you show the clear stent? Because balloon is actually there. Clear stent can be demonstrate whether we have covered the ostium or not. There is a crush created, but the ostium actually, probably because of my high dilatation of the balloon, you should actually understand that we have done a initial cutting balloon with a 3 millimeter in the ostium for both the vessels and then did this case.
So what we see here, there is some compression of ostial stand in left vein. So you need definitely one more final pot.
Kiss. Final pot or final kiss.
I would suggest final pot.
Final pot only you require.
Yes, and
Yes.
of course, and then final imaging.
Final imaging we'll do very fast, and we'll do one more pot and then take a final imaging.
Yes, perfect.
And we will leave with you.
Yes,
Just
but
I'll
I
take-
think it was really very tough case, and you could demonstrate in excellent way how to approach safely. I personally probably would go with Dicky Culotte, but you was sure you can manage this case with Dicky Crush,
15.
and it's perfect
Yeah.
demonstration. So very
Probably we actually deflate. We usually do DK crush all the time. DK culotte also we do, but DK crush is actually one technique I always like. So
I would like to mention that we do in Germany now, there is ongoing randomized study comparing Dicky Culotte with Dicky Crush in 400 randomized patients. So
what is the initial result published or nothing? No.
No, we are still, the study is ongoing. So we still need maybe 1 year to be ready with randomization. Because this
What is the advantage of the decay culotte? What is your experience? What is the advantage?
Advantage of digging culotte is that you have practically first choice is to work with one stand. If you need second stand, you can go with second stands. This is more or less.
We will, we will
back-
actually
back
do the
tap.
OCT. The
I
OCT
think it's a
can
much
just-
simpler procedure compared to multiple crossing and recrossing. So that's the advantage.
Yeah.
So if the outcomes are the same, then one could say that just go with a simpler approach. Oh, what wire is this over? Pratap?
So far, so I actually, my workhorse wire is Fielder FC. You know, I do a lot of CTOs. So this is the wire I use, the simplest of the wire I feel. All other wires I use as very tough wires.
And the OCT is over which wire? The LED?
Fielder FC. So this is actually the very short full I used only is 5 ml of contrast here and then taken a shot and then let us see the final result.
We have excellent impression.
Ah,
It
yeah,
looks, perfect.
Yeah.
Even
con-
just focus your attention to 3D picture. Yeah, we can see now the ostium of Cirque.
Very-
It makes
Ostium of Cirque is very
Yeah,
good.
that's right, very good.
And what is the area? Can you just tell the LED ostium? What is the area? And we did not lose the ramus for the attention of Dr.
Yes,
Radhakrishnan. That balloon dilatation did very well, and that has actually produced a good result. And I think this patient, we could give a reasonably good result.
Yes,
Yes, yes.
perfect result.
Yeah.
That's a fantastic result.
I-
Congratulations.
Yeah. I
Congratulations.
especially congratulate to the Prathap finishing the 10 stages of DK Karas within 10 minutes. Thank you, Prathap.
Thank you, sir. Thank you very much, sir. Thank you for being with me. Thank you very much.
Okay, thank you
And
so much.
My point is actually we could demonstrate 3.5 stand in a 3 millimeter demonstrated image. That is what yesterday Saurabh and me was fighting with all the people. Nobody was believing that. Luckily, I could demonstrate that today. Thank you.
Thank
very
you,
much.
thank you.
That was
Pratap,
fantastic.
Thank you.
anyway, great show, but that's why he kept you in the end, man. So that
That
you'll
is
show
why
it
actually
better.
I'm always
Thank you.
the last
Yeah.
batsman.
Thanks,
He actually-
so that you'll
thank you.
show it better. Thank you, sir, for
Thank you.
conducting. And
Thank
we will have